Hello and welcome to Health Tech Builders. Here we explore the business of health innovation through real stories from leaders in the trenches, the wins, the failures, and everything in between. You will get insights and practical advice to help you build and lead in health tech. I am your host, Rodrigo Hute. Hello everyone and welcome back to the podcast. Today my guest is Adam Siskind. Adam is a principal at CS Associates, a global consulting and technology firm that specializes in healthcare and life sciences. Currently, Adam is responsible for leading CS efforts in health plans and providers. Adam, welcome to the podcast.
Thanks, Rodrigo. Pleasure to be here.
I'm excited to learn from you, Adam, today. And I know that your team conducted a survey with 12,000 patients and 1,500 providers across 7 countries, and the results paint a stark picture. On the one hand, you have patients that say that they feel less cared for. Also, nearly 90% of healthcare is unaffordable. And also, American doctors say that they remain cautious on AI. So in this episode, Adam and I, we would like to unpack these findings and share also some practical steps leaders can take to improve affordability, access, and physician time with patients. So with that, Adam, let's get started.
Sounds good.
Let's talk a little bit about the survey methodology. I know that your team conducted this survey with, as we already said, 12,000 consumers, patients, and 1,500 providers. How long did it take to run this survey? And most importantly, what was the biggest surprise that jumped out to you from the data? Something that you didn't expect going in.
Yeah, it's a great question. So what's important is this isn't the first time we've done this survey. We've done this survey the last number of years, so that we see not just a point in time result over the 3 months that it takes to collect all this data, but so that we can see trends over time, not just trends across the 12,000 consumers, healthcare consumers, and the 1,500 providers, but over time within specific countries, so that we can see changes. Those changes and the variability across countries are really where most of the insights come in. I think the variability where things are inconsistent helps to identify opportunities for change. And so to your point, what we're looking for is to use this as a means of thinking through what can change, what's really popping in terms of trends, and what may change. And so to your point, there are things that are, I wouldn't say that surprising. Patients feel less cared for. I don't think that's all that surprising. Affordability being an issue. I don't think anybody would be that would be eye-opening for a lot of people. Things like access bottlenecks and health inequities. These are things that people have been talking about for many years. But where you start to see some really interesting trends is where you look at some of that inconsistency. So an example of that inconsistency is, take patients as an example. In the US, what people are experiencing are that about a third of patients feel appropriately cared for. A third of patients feel appropriately cared for. That's not great. What's really interesting is that physicians feel that that's probably around 80%. When you ask physicians how many of their patients feel cared for, they say, oh, I suspect it's around 80%. Mm-hmm. Now that gap is a huge issue. That gap was eye-opening for us as a firm. When we saw that gap, it suggests that the solution isn't going to be coming from providers necessarily, because providers think that things are fine from a patient perspective. They don't think things are fine from their own perspective, right? They say that they're overworked. They say that they're not getting the tools necessary to support patient care that they'd like to be able to support patient care, or they don't trust the tools that that are being needed to support patient care the right way. But they, at the same time, feel like, oh, but patients feel like it's okay. Well, patients don't feel like it's okay. And so that gap, I think, was pretty eye-opening and stark for us to hear and see.
Yeah, that's actually, let's unpack that a little bit more, Adam. But that's actually what, the survey report that you published talks about a number of key results, takeaways, and this is one of the main findings that I was able to read. And it's that patients feel less cared for. And yes, it's not surprising. I would agree with you. But why is this happening? Why is there a big disconnect between how patients/consumers feel and how doctors perceive reality?
Yeah, so that's the right question. So why do patients and physicians have this discrepancy around their experience? It's because physicians don't see the entire experience that a patient goes through, right? What they see is the amount of time that they spend with patients. And so from a patient's perspective, that's about a third. What the survey tells you is that that's about a third of the time they experience in trying to help themselves in their healthcare journey. Two-thirds of what a patient experiences is outside of that direct patient-physician conversation. Right. So a lot of the two-thirds that they're spending outside of that conversation is wait times, is trying to get an appointment, is trying to do some of their own research on their own behalf so that they're going into an appointment with some knowledge. And all of that two-thirds is a very frustrating experience filled with misinformation, misdiagnosis, filled with a lot of anxiety related to
billing as well.
And I haven't even talked about the back end, which is once they get their prescription, that leads to things like prior authorization notifications and billing issues and things like that. So that two-thirds of time the physician doesn't see and experience. They just see that third of the time that they're spending together. And so from their perspective, that third of the time is fine. And for the most part, that third of the time is fine. Physicians would like more of that time. Where they say that their experience isn't amazing is because they would like to spend more time with patients, but because of the administrative burden, they can't. They could only see their patients for a certain amount of time. Patients are saying the exact same thing. The burden of what they're experiencing leads them to the less amount of time with a physician and more amount of time with as you say, billing or the administrative process or misdiagnosis and things like that, seeking other healthcare professionals. And so that's really where that discrepancy comes from.
There is also another point in the survey where you guys show that patients are more willing and open to interact through virtual channels, AI tools, and so on. But at the same time, there is this willingness and openness, while at the same time there is less trust. And so there is also a disconnect there.
Yeah, not only is there less trust, and this is where the variability across countries come in really handy. So let's focusing on the US, right? In the US, less than 40% of US physicians trust AI. Patients trust AI more than physicians do. Not a lot more, by the way, but a little bit more like 60% for patients. If you were to contrast that with India, India physicians trust AI. 97% of physicians in India trust AI. 97% compared to less than 40% in the US. And so that's a huge gap. In China, it's 90%. In Japan, it's 70%. Even in the UK, which is not too dissimilar, it's around 50-60% of physicians that trust AI solutions.
Why is that?
So less than 40% in the US suggests that their physicians, because of that distrust driven by things like biases, privacy issues, patient safety, ultimately things that AI might get wrong, and overconfidence in a physician's ability to get it right more often. That leads to them not necessarily trusting AI the same way that somebody in another country might trust AI, and leading to this discrepancy around and this gap that might lead to more efficient solutions, but those efficient solutions require a little bit more of an engagement with technology and AI.
Now, there is another key finding that you mentioned earlier around affordability. Mm-hmm. And we know that this is not news, right? We all know that, especially in the US, I think the US spends like 80%, 18% of healthcare, of GDPs of the US in healthcare. And the survey says that 88% of Americans say that that healthcare is becoming less affordable. Mm-hmm. So I'm wondering, like, how much of this is perception versus reality, and most importantly, do you think this can be solved? I mean, the cost or inflation, or this is just reality?
Yeah, that's a big question, and there's lots of pillars related to that question. Can it be solved? I mean, I think yes, it can be solved. Many other countries have figured out ways to solve it through more centralization, through increasing the buying power of those who purchase healthcare. In other countries, the government is the main purchaser of healthcare. In the U.S., the largest payer is CMS. The largest payer in the world is CMS. But I wouldn't necessarily say that they exert their strength the same way that other countries may exert their strength. That's starting to change, but not necessarily to the point where it's offsetting the perception of increasing cost of care in healthcare. And the burden continuing to shift to the patient with increased premiums and so on. That does create a large burden. So if you are not covered, if you are one of the millions of Americans who are not covered through their health insurance, or not adequately covered, the wrong disease, the wrong diagnosis can bankrupt a person still, right? That still exists. And so that's why you're seeing this this trend continuing to go in the wrong direction. But it can be solved. It can be solved through what other countries have done by increasing payer power. It can be solved by thinking about what's necessary in terms of care versus desired in terms of care, and what is being paid for and what is being put onto the consumer. This idea of cost versus quality of care is a measure that other countries use on a fairly regular basis, whereas the US doesn't use that kind of measure to assess what is being covered and what is not being covered. But it's a very politically charged conversation around should everything be covered versus should only certain things be covered, and what does that implication mean for medication, or for diagnostic techniques, or for other forms of healthcare? What should be covered? What shouldn't be covered? Should that be up to the patient? Should that be up to the government? That's a really big question. But there are ways to control for that that other countries have learned and have put in place to help control their costs. But then, as we see, there's a big discrepancy in what is funded in the U.S. versus not funded outside of the U.S. Versus funded outside of the U.S.
Yes. Another thing that I would add, it's also potentially culture, the role of culture in the U.S., where what I've seen is that people living in the U.S., they like to have choice and optionality. So by being able to have a broad menu and being able to have the choice to decide, that also could potentially increase costs as well.
Sure, and choice is fine. I mean, other countries have choice as well. Take the UK as an example, where they have a very clear two-tiered system, right? They've got a very clear public system. They have a very clear private system, and that allows for choice based off of affordability. It just makes sure that those who cannot afford healthcare can still access healthcare. And those that can afford a different level of healthcare, they can also afford a different level of healthcare. And so that's a system that allows for choice and still make sure that the inequities that exist don't get in the way of somebody's quality of life. Maybe you might wait a little longer for care in the public system in the UK, or maybe you might not necessarily get access to a private room. You might have to have a shared room in a hospital. And so that those differences wouldn't necessarily impact what kind of quality of care you're getting. It only impacts the experience. And that's a huge difference that other countries have been able to manage.
What's the role of staffing in inflation? And we know that healthcare staffing, it's an issue. There is more demand than supply. Also salaries, compensation, because of this imbalance, supply-demand imbalance. I would imagine that it should be playing a big role in affordability. Mm-hmm. Would that be accurate to say?
Yeah, for sure. And again, I'm drawing these comparisons against other countries. Staffing shortages in other countries actually worse than the US. And so where they have been able to manage the maybe the affordability question with a little bit more effectiveness since COVID, and with all of the burdens that are placed on a healthcare professional, the shortages that you've seen in places like the UK and France and Canada, where they do manage the cost of healthcare when the care requirements spiked through COVID, the shortages became more drastic. And so it's a really challenging thing to balance. I wish I had the right solution there. But you can see where there is more pressures on that supply-demand equation. It's where the affordability questions have become more of an issue. Or because of how they've tackled the affordability, it's put more burden on the supply.
The other finding in your survey is access, and we touched on this, but I would like to unpack it a little bit more. And access is not something new, right? I think in the US we have seen challenge, not only in the US, but I think the US has a big issue in this area. But it says that one in three Americans lack access to primary care, mm-hmm. and primary care physicians patient loads are rising worldwide as well. Mm-hmm. I think you mentioned Japan seeing 100+ patients. It's increasing. So just wondering, are you seeing any differences in trends and anything that is really helping in terms of improving access?
Yeah, so there's two sides of the access equation, right? One is busy physicians who aren't able to take more patients, and one is patients who are not proximate to the right healthcare professional. Right. So both are being tackled. Right. So in terms of physician time and energy and the time that they can't spend with new patients, the idea of trying to reduce their their administrative burden. There's a lot of efforts that are being placed in provider organizations and hospitals, health systems, to reduce the administrative burden. We talked about AI, where AI is having the biggest impact, is in areas of reducing the administrative burden. We can talk more about that later on. So that covers the busy physician problem. Doesn't erase it. It just that's the main area that people are focusing on, is trying to reduce that administrative burden. For patients who don't necessarily have access, that's where virtual telehealth, virtual means of accessing healthcare are becoming more important. Ambulatory solutions are becoming more important. So taking the patient out of the hospital and applying care out of the hospital to allow for somebody who doesn't necessarily have the same access to a local primary care physician, or where their local primary care physician is too busy. That's where you're seeing a lot of virtual care going into part of the solution set. Again, not perfect, but that's where you're seeing a lot of the innovations happening. Unfortunately, the challenge is sometimes the folks who are in the community are the ones who are least comfortable with some of the analytical technology tools that are required for virtual care. And so that's one of the things that needs to be addressed, is how do you drive adoption of virtual care when virtual care is going to be the thing that's going to be most important for your care.
And why would, in the case of the U.S. Landscape, there's some recent news where I think Medicare or CMS cutting back or reversing funding around some virtual care solutions. I don't know if you have come across that.
Yeah, I mean, it's a desire for reduction in cost overall in the healthcare system, and so there's lots of different areas where they're trying where reduced funding is leading to reduction in services like telehealth. And I can't speak to the decision on doing that, but the implications is that it's going to go against what I just described around trying to create more comfort with virtual care in communities that require more virtual care. I mean, if you look at areas like Africa, virtual care has become the norm, where you don't have the same access to primary care physicians. India is another good example where that virtual care adoption has become much more advanced than in the U.S. And so I think that the U.S. can learn from countries that are adopting and investing in virtual solutions to help reduce the burden on physicians and to increase adoption in the community. I think it's a shame that some of the investments have shifted. It doesn't necessarily require money; it does require time and effort, and maybe some of that funding does happen in the states where the rural communities are a little bit more prominent, and where the care is required a little bit more with a little bit more focus.
Yeah, definitely. I think it's what you said earlier. It's a desire to cut costs across the board. Mm-hmm. It's a primary driver for sure. Then let's go back to the fact that physicians are drowning in more work and admin work and burning out. This is not, I mean, I've been hearing this for a long time. Are there any key differences between this year's survey versus previous surveys in terms of changes in this? Are they finding better solutions or tools or approaches that are actually freeing up time for physicians in a drastic way?
Yeah. So while the results of the survey haven't necessarily changed all that much in terms of the burden, the administrative burden that they are all experiencing, there is more AI adoption. Even though, as we talked about before, there is lack of trust, but there is more AI adoption. And where is that adoption happening? It is happening in the areas that are there to reduce clinical burden. And so that's a really good thing. So what are those areas? Those areas are going to be in things like coding to help with payment, prior authorization, things like that. The most obvious ones are clinical note-taking tools. So those clinical note-taking tools are the ones that are being adopted most prominently across hospitals and health systems, and so that is slowly becoming the norm. I mean, I've seen physicians who have said, "I don't want to adopt that. That's going to get in the way of I'm going to be thinking about that in my day-to-day interaction with patients." But for the most part, most physicians are adopting ambient listening tools that are integrating the notes into an EHR system. So that's great. That does reduce a lot of the administrative burden. Now, it needs to be tied to the decisions that are being made that a physician needs to inform. And so those are going to be things like appropriate coding, appropriate ways of managing prior authorization, more of the administrative stuff. You can also apply this to areas like patient experience. And so how do you tie the right care management program to the right diagnosis, depending on where they are in their disease journey? And so that's where I think the AI solutions are becoming more and more impactful, where I believe that the administrative burden is actually dropping, even though I think it'll take a couple of years before physicians really experience that.
So perhaps the lack of trust is not necessarily on what AI can do with, with admin work, but more to do with clinical decision making.
That's right. I think when it's tied to patient outcomes, when it's tied to diagnoses, and that diagnoses getting in the way of what a physician believes that they should be doing, that's where that distrust is greatest. And the reason is because hallucination can happen. And it's possible that what you're going to be suggesting, if you're an AI solution, what the AI solution is going to be suggesting to a physician might be incorrect. And so, not too dissimilar to the self-driving taxi. The self-driving taxi could potentially lead to a very bad outcome, even though for the most part it will lead to better outcomes than a person who's driving a taxi. But one bad outcome would be a disaster, even though 10 taxi drivers might lead to a bad outcome. And so you're kind of dealing with a very similar situation, right? It's a very similar situation where 10 physicians or a physician making 10 diagnoses might be incorrect, but if one AI solution is making one diagnosis and that leads to an incorrect treatment, that's a disaster. And so that's where the trust needs to balance with the having a physician in the middle. The answer is what I just described: having a physician in the middle, making sure that you are not providing a diagnosis to a patient without a physician checking that diagnosis. And so if there is an AI solution that's predicting risk of progression of uncontrolled A1C for diabetic patients. So type 2 diabetic patients, they're uncontrolled A1C because of non-adherence to medication, or because of small progression in their A1C, higher variability in fasting glucose, things like that could lead to an assessment of their uncontrolled A1C progressing, as an example. An AI solution might be able to identify that quicker than a physician might be able to, or they might be able to assess that through some sort of interaction with their blood glucose monitor, a virtual device. And so that's a really powerful AI tool, but I wouldn't want that to just go to the patient making decisions around their dosing, if they're on insulin, for example, or on progression of an oral medication from a metformin to a DPP-4 or something like that. I would just be very cautious that the patient should be using this using any sort of information as an opportunity to talk to their endocrinologist, to talk to their primary care physician before making a decision. Having the physician in the middle is a really important part of that process. We're putting a solution together as an interesting case study where to help with clinical trial recruitment. Well, that's based off an inclusion-exclusion criteria. You can use an AI tool to help with the identification of a patient who is likely to meet that inclusion criteria. And for a large hospital or health system where the principal investigator is not seeing most of the patients, they're seeing their patients, but they're not seeing 90% of the patients who might qualify for this particular trial. Having an AI solution helping with identification of a patient who might meet an inclusion criteria, that's a really good solution. But that requires the PI, the principal investigator, to identify whether the AI was right. they're not going to bring anybody into the trial unless they know that it's the right patient. So it's a really good example where the physician is in the middle of the solution, the AI solution, so that you end up with the right patient being put on the right trial. Okay, so that's an example where even in the case of patient diagnosis, patient matching, that's where an AI solution tied to physician knowledge and experience, that's where I think you can have some really powerful outcomes. Where you're delinking the physician from a diagnosis, that's where it's more fraught with risk.
Yeah, the combination is powerful for sure. And in terms of, I mean, you talk about AI readiness in your research report, and you also mentioned about the self-driving car example, like Waymo. And I was reading, actually a few days ago, that it took Waymo, about 20 years to make the product like fully reliable. And maybe the technology was already there, but it took time. It took 20 years from developing the new technology, and yes, it has been evolving over these years, but it took a long time to being able to roll out a new technology, and people are now starting using it across different cities in the US.
Yeah, that's it. As I like to say, it's way more time than it should have taken.
Yeah, exactly. And related to that, like, what's your prediction? And I know that predictions are super hard, but what's your prediction in terms of how quickly do you think physicians are gonna feel to adopt AI for clinical decision making, diagnosis, and tying it to their clinical work? Do you think it's gonna take 20 years, like what it took Waymo, or do you think it's going to be faster?
Well, it'll be faster than 20 years, but not a lot faster. Now, there's different dynamics at play, right? So one dynamic that's at play is, in the case of Waymo, there were only a couple companies that were developing a self-driving car at the time. And so you didn't have the same amount of flooding of the market to drive adoption that you have in the clinical world. So in the clinical world, you've got thousands of apps and companies that are trying to build applications for self-diagnostics, or to help in the workflow of a physician to help them with their diagnostic technique. So you got 1,000 of those solutions, not just a couple self-driving cars. And so there is a lot more opportunity for adoption. But as I said, there's a lot more reluctance, especially in the US, right? That's back to this less than 40% who trust AI. And so you will find the adoption happening a lot quicker in places like India, in places like China, in places like Japan. You'll find that adoption happening a lot faster there. And so the reason why you'll likely to see greater adoption in the US than you saw with Waymo is because you'll have experiences, real life experiences outside of the US that are going to happen a lot faster than you saw with self-driving cars. And so those direct experiences and clinicians in India who are sharing their own experience of how this has helped them and their experience, you'll start to see data, real life data with real world settings showing that that this does work in other countries. And so I suspect that will lead to faster adoption in the US than Waymo. But I don't think it'll lead to a lot faster adoption because mistrust is hard to manage, right? Mistrust around things like inaccurate diagnosis, mistrust in things like patient privacy, mistrust in things that are inherent to why the adoption isn't as strong as it is right now. But there are, as I said, there's definitely forces that Waymo didn't experience that I think will help speed up that adoption.
I find that very interesting that you say that it's going to take the US to see other countries implement this, like India. You mentioned India and other countries, to to use AI for clinical decision making before it fully penetrates the use in the US, where I think that it was the other way around for other technologies and most innovations. It started in the US, and then other countries said, oh, it's happening in the US, now we have to adopt it. What's changing?
That's a great question. I mean, and it's already happening in outside of the U.S. So take like Apollo Labs in India. They have developed algorithms for earlier diagnosis and risk identification in cardiovascular disease. And so that is being used across Apollo, which is the largest health system. I think one of the top 5 health systems in India, if not the largest. And so that's being used in a way that's very different than how than how similar technologies are being used in the U.S. So it is different. And so to your point, why is it different? I don't know why it's different, other than concerns of getting it wrong, and the legal system in the U.S. that is related to getting it wrong. That those legal issues are in many ways what drove the Waymo to be a 20-year development plan. And so I suspect that the legal environment in the U.S. is a different infrastructure than you would find in India.
Yeah, that makes sense. Yeah, at the end of the day, there's this liability issue, like an AI won't be responsible.
That's right.
Right. So yeah, that makes sense. All right, so let's move on to the last part of today's podcast, and you have a section on your survey on your report that talks about the treatment plan, and I wanted to ask, like, what are some of your practical and tactical recommendations for healthcare leaders moving forward? If you can share some of those, that would be great.
Yeah, so I think in terms of where you're going to be applying your AI solutions, I'm focusing on AI as a means of reducing clinical administrative burden. It is in this area of administrative burden. So if I'm part of the C-suite of a hospital, the first thing that I'd want to be doing is figuring out how can I leverage AI to make things more efficient. Take clinical trials as an example. I already talked about clinical trials. So the clinical trial authoring process is a very time-consuming process where you have tons of documents, 20 documents that you need to put together for any clinical trial that you might want to drive in your hospital. Well, all of those documents can be streamlined. So we've got some solutions that help to streamline that document authoring process for things like informed consent forms, for IRB submissions, for FDA submissions, for pharmacy protocols, and so on. And so all of that authoring takes a lot of time and effort and funding to enable any clinical trial. And so the cost of putting a clinical trial in place, whether it's an industry-sponsored study or whether it's through a provider organization, an IIT, an institutional initiated trial, those clinical trials are very costly and time-consuming, resource-intensive. There's ways that you can streamline that a lot, so that the research assistants, so that the nursing support, so that the PIs are spending their time in patient care and identifying the right patients, as opposed to writing documents. That's a really easy example of where you can streamline a lot of time and effort. So relieving clinician administrative burden, prior authorization we talked about, putting the right codes in place so that you can reduce the burden both on patients and on physicians. Those are the kinds of things that are critical. So it's tied to a couple recommendations we have, right? Reducing the burden on clinicians, that administrative burden, and designing AI to augment and not replace people. It isn't about replacing healthcare professionals, it's about augmenting them and helping them become more effective or more efficient. And so those are a couple easy ones, easy places to start in terms of prioritization. I think the other place where analytics and AI can help is in the patient experience. So making sure that their experience, as we talked about initially, where a third of their time is in the care of healthcare professionals and two-thirds of their time is outside of that, making that more seamless so that the demand and the supply is a little bit more effectively matched. And so thinking about how can you leverage some of the tools to help with care management programs so that when a patient is diagnosed with a particular disease, how do you make sure that you've got the right program tied to the right patient and have a little bit more micro segmentation, for lack of a better term, so that you're putting the right program with the right patient at the right time. That's often the best use of analytics, so that you can look at large data sets so that you can say, oh, this is the kind of patient that is going to respond the best with this kind of program. That leads to better patient experience, which should lead to better health outcomes, but definitely should lead to just a better experience overall for the patient. So that's critical. Getting more experiences with AI so that you can start to build that trust in AI amongst physicians and other healthcare professionals, that experience coming from, as we talked about, potentially other countries, but just using AI for administrative tasks helps them get more comfortable with using it for patient experience and for potentially patient outcomes. Okay, so building that kind of trust, building champions in a hospital, in a health system, amongst payers and so on. And then often the most challenging thing is to take that comfort that maybe one clinician might have, and then how do you scale that across the hospital? And so that scaling is where you need to have a really strong change management team to help in scaling a solution across the hospital. It can't just be build it and they will come, but it needs to be put in the right champions, build an ROI model, think about the outcomes that you're trying to drive. If that ROI is based off of adoption, that's okay. It doesn't just have to be greater profitability of a health system. It could just be, we need adoption. That's the outcome that we're trying to measure. So all of those are the 5 recommendations that we focus on, right? Scaling, driving adoption of AI solutions, meeting that consumer demand, relieving the clinical burden. So these are all the areas that we would focus on.
You mentioned that's great. Thanks for sharing that. One of the areas that you mentioned, it's AI to augment, not to replace.
Yep.
Do you see a world where, for example, AI could potentially replace radiologists, for example? And, there is a lot of, there is like 2 schools of thought, where there is one group of people that say, oh, they might not replace radiologists and radiologists might not be out of a job, but, AI could potentially do 80% of a radiologist job or work. What do you think about that, for example?
So from the experience of other areas where that same conversation is around replacing versus augmenting. So in the legal arena is where a lot of people are saying, hey, AI can replace what a lawyer is doing these days. Well, I personally don't think that an AI tool can replace what a lawyer is doing, but it can replace all the documentation.
Yeah.
And so if a lawyer is only doing documentation, well, yeah, AI can replace that documentation, but a lawyer is doing a lot of thinking around that documentation. And so maybe the AI can replace a lot of paralegals, but it can't necessarily replace the lawyer. Yeah, right? You still need to have somebody who's really thinking about the strategy around a document that you're trying to draft. It needs to be thinking about how do you use this for an effective negotiation with whoever you're working with. And so that's strategic design thinking that is where AI can help augment and allow you to focus on that strategy. So that's the parallel for radiology. I think a lot of the technician work can be replaced, but I still want to have a radiologist looking at the diagnostic that an AI solution might be providing and saying, you know what, that's right. But I want to do the following labs to make sure that it's looking at the tumor size in the right way. And maybe what I'm seeing on the lab report, the size is a little blurred from what the reality might be. And so there's a number of things that I would want to look at if I'm a radiologist that an AI solution might not be able to get right. But AI with the radiologist is a really, really powerful tool. And I might not necessarily need all the technicians that I've had in the past.
Yeah, you will
That's my
still
own
be.
perspective. Others might have different perspective, but that's my perspective.
I think that makes sense. I mean, you still need the thinking, the strategy, the judgment, and all of these things that will not be completely replaced
Right.
by a machine. All right. So Adam, thank you so much. I have one final question. One final question before we go, and I wanted to ask you, how are you personally using AI in your life and work? What are the use cases or tools that you have found most helpful to for you to your life and your work?
It's probably the same area that I suggest to my clients, which is provide some hypotheses before you start to go down a particular path. Make the administrative burden of my day-to-day life a lot easier, and so I use GBT for lots of things to make my day-to-day life a lot more efficient, so that I can spend my time thinking, designing solutions, implementing those solutions. And so, things like my time entry process, or things like putting together PowerPoint presentations, and things that aren't necessarily as much value added as the thinking behind them. And so it's allowed me to spend more time thinking. Hopefully that thinking is useful for my clients and for others. Or maybe it just puts more of a spotlight in the erroneous thinking that I might be putting in front of my clients and my and my peers. But for the most part, it allows me to spend more time thinking, and thinking about implementation, thinking about problems, thinking about the solution set, as opposed to all the more administrative stuff that I do on a day-to-day basis.
So what tool are you using for PowerPoint for presentations? And have you found any other tool for data analysis? And I know that when I was a consultant many years ago, I spent a lot of time crunching numbers in Excel and doing PowerPoint presentations. Are you using ChatGPT for that, or have you found any other tools that do a good job in helping you build that?
Well, luckily we're an analytics shop, and so we got 15,000 people that do this for a living, and so we've developed some homegrown tools that are better than,
Nice.
And so some of our homegrown tools are actually things that we're leveraging as assets that we put in place for our client solutions. So we got a lot of people helping to build efficiency driving tools, and then Copilot will sometimes be a better solution in PowerPoint. Sometimes GPT will be a better solution, but ultimately, we're trying to build a lot of different agentic solutions to help with point solutions for specific problems. And so we're often using our own tools that we've developed for our clients, for ourselves, and vice versa. Bringing the solutions that we develop for ourselves for our clients.
Yeah. Excellent. Sounds good. All right, Adam, thank you so much for being here today. Thank you for sharing your knowledge, your experience with all of us. I appreciate your time. And thanks everybody else for watching or listening. Until the next time. Thank you.
Yeah, thanks, Rodrigo.